So hello and welcome everybody to the webinar that we're running this evening on Shockwave Challenging Your Practice. I'd like to say thank you for everybody for joining us on this warm sunny evening. Just for you on the format of the webinar, it's going to be split into two sections. We have a 20-minute presentation and then an interactive question and answer session. But just before we get started, a little bit of housekeeping. The session is being recorded, and you'll get access to this after the webinar is finished, probably tomorrow. So if you did miss anything, then you'll be able to look back on it. But if you are able to mute yourself, then please do. And if you do have a video, it'd be great to see who's on. So if you're able to share your video, that'd be great. And any questions for the Q&A session, there is a chat function at the bottom of Zoom. So if you do have anything, then you can pop your questions in there and we'll get them answered. So just a quick introduction. My name's Dominic Smith and I'm the clinical specialist for Focus Shockwave at PhysiQuip. Now we were introduced to the piezo wave Focus Shockwave system from our colleagues in the States and Australia. And since we've been working with it, it's been really exciting for us. We've worked with several private clinics around the UK and Ireland, from large to big, also large to small clinics. And we've really seen how Focus Shockwave can help grow the business and set these clinics apart from many others in the areas. And from this, we now work with diagnostic ultrasound, so we've expanded into that area because we've had feedback that this is considered as best practice for Focus Shockwave, and we felt it was really positive for us to be able to offer that full solution. So with that being said, on to introduce Dr. Anders Brogard, who is leading the session today, and he's joining us from Denmark. Now, Anders has over 20 years of clinical experience in using Shockwave. So if you do have any questions, tonight is a really good time to ask anything around clinical application. So any particular injuries that you have any questions around, and also the working mechanisms. Anders can hopefully answer as many as he can. But otherwise, with that all being said, I will hand over to Anders to start the presentation.
Thank you, Dominic, and thank you for inviting me to this little webinar here, where I'm going to talk a little bit about shockwaves. As Dominic said, I've been using Focus Shockwaves for nearly 20 years. I work in Copenhagen at a private clinic, a multidisciplinary clinic, where we work chiropractors and physiotherapists together, where we try to diagnose, treat, and rehabilitate primarily spinal and sports injuries. We work very close together with sports physicians and orthopedic surgeons to manage our patients. And we have X-ray, ultrasound, and MRI facilities to help us diagnose our patients. And especially ultrasound we use quite a lot for these musculoskeletal conditions that I'm going to talk about tonight. We only got 20 minutes, so I'm going to rush through this little presentation that I made, and afterwards we can have a little Q&A. So what is a shockwave? As these sightings here says, it's a shockwave, it's a sonic pulse that has certain physical characteristics. It has a high peak pressure, more than 100 megapascals, and a very short lifespan. It has a fast initial rise pressure on a very short duration, which is followed by a negative and tensile phase. So these are the characteristics that we actually use in these orthopedic conditions. This is how it looks like in a graphical setting here again. You see the initial rise phase over here, followed by a negative tensile phase. It creates a high pressure in a very short time span. And this initial rise phase is actually what gives the shock effect to the tissues. And this negative tensile phase you follow here is shown to have a form of vacuum, a tensile phase on the tissues afterwards. So this whole wave pattern actually creates these biological changes that we see in practice. Just to compare it with some other technologies right here, you probably heard about radial pressure wave, which is also actually included sometimes in shockwave therapy. We have a difference here that these two technologies, they differ in the regeneration devices, the physical characteristics, and the mechanisms by action. And in the following, I'm going to primarily or only talk about focus shockwaves because the wave pattern of the focus shockwave is the only technology which has shown that it has some effects on the biological tissues that I'm going to show you in a little while here. Radial pressure waves are also used widely. We also use it in our clinic, but it's different. And it's generated by another technology. Typically, it's an accelerated projectile, which is accelerated by compressed air. And it's then hitting the end of a metal tube and transmitting the energy to the superficial tissues that you actually apply upon. So this technology has, let's say, less power or pressure, and it has another wave pattern. When we compare the two things here, it's like two different technologies. The shock wave is about 100 times stronger than the pressure waves. The energy of delivery is much faster, which means that you can actually, in a short time span, deliver much more energy in a treatment with the focus shock wave than you can with radial shock waves. As I said, we use both technologies at the clinic, and I prefer using the pressure waves for more superficial and larger areas to get tissue changes into the treatment, whereas the focus shock waves we can actually concentrate and use deeper into the tissues in the body. This is an illustration of how it looks. These two devices here to the left are focus shock waves, which illustrate that we actually produce a focal zone of shock wave, which is shown here in this cigar-shaped illustration, and it can be displaced into the body, deep into the body until 10 to 12 centimeters, whereas the radial devices over here deliver the maximum energy at the superficial level, and then they dissipate into the tissues. We have three ways of actually producing these focus shock waves. The oldest technology is the electrohydraulic, and all three technologies work by actually applying a high voltage discharge into the systems. And with the electrohydraulic system, we actually create a spark plug between two electrodes, and they produce a plasma bubble, which actually again are focused and are creating this focal zone that you see up here, which we can target the tissues with. The next technology which was developed was the electromagnetic. And here we actually activate a flat or cylindrical coil, which actually is reflecting on a metallic membrane, and these are then focused to produce a shock wave. And the newest technology is the piezoelectric one to the left, where we have a device which is actually covered with lots of ceramic plates, and by applying a high voltage discharge, we cause some expansion of those, and due to their arrangement, they can actually be superimposed, and they again create the same cigar-shaped focal zone of shock wave, which we treat the tissues with. There's a little bit of difference in how homogeneous these energy fields are, how deep they can be penetrated into the body, and how large they are. The older electrohydraulic devices produced a focal zone where the energy levels were quite different from shock to shock and not homogeneous, so they were not as solid or energy dense as the newer ones, whereas the newest piezoelectric device actually produces a very, very dense and homogeneous energy zone, which we can target the tissues with. That's something that the patient can feel and respond to when we actually treat them. There's some few technical values that you have to be aware of when you're talking about these pressure zones and focal zones, is that we have a pressure field, and that's the maximum pressure at the focal center. Then we have what we call the energy flux density, which is described as millijoule per square millimeters, which is what we use clinically to actually address the different tissues with the different energy levels according to what we want to achieve with the tissues. And then we have the total energy that we deliver to tissues, and that means how much energy or how many shocks we deliver at a certain energy level to the tissues at each treatment, and how many times we actually apply that treatment for the patient. As you can see, I just listed all different kind of manufacturers right now on the market, and you don't have to go into detail. And I have worked with all of these systems and tried them off with my patients and developed different treatment regimes for each technological device, because each differ in the size of the focal zone, the energy delivery that the machine can actually produce, the density of the focal zone, and the penetration, and how you work the system by itself. So you have to take into consideration what device that you use and apply that, and make your own technical parameters and treatment protocol for each of those systems. They all have advantages and disadvantages, and what I'm going to focus on today is the piezoelectric device, which we use at the clinic together with the other sources too. Another thing that's quite interesting is that each of these systems actually produce a focal zone in different sizes and depth. As you can see here, the Shockwave systems actually produce a smaller focal zone, but very dense and very precise, whereas the older electrohydraulic devices produced a larger field of focal zone, and that can have their advantages and disadvantages, whichever, depending on whichever anatomical area that you want to treat. This device here we are most fond on right now. It's the Shockwave 2. We have 3 devices at our clinic, and we use them both physiotherapists and medical doctors and chiropractors. It's a very easy to use system, starts up and shuts down very fast. It's low maintenance care, and it's, in my experience, the most powerful tool that you can use for the deeper lying tissues, and it's very precise to use, especially if you conjoin the treatment with diagnostic ultrasound, which we always use. The piezoelectric technology has one advantage in front of the other systems, is that they develop this linear focus. So we have several head pieces here. We have this traditional one, which produces a cigar-shaped focal zone, but then they develop this and patented this linear focus, which is a very broad area. And due to its linear, it can actually be adapted to linear anatomical structures in the body. And because we see a lot of muscular tendinous and ligamentous injuries, it's very easy to apply on these tissues, and you can actually target the tissues within 1 or 2 settings, and that speeds up your treatment quite a lot. This is how it looks like. So this blue focal zone is actually where you can treat the tissues. So as you can see, with a long tendon like the Achilles tendon, you can apply 1 or 2 places, and you can actually treat the whole area, and also the surrounding tissues, which are often also involved in the pathology that you see there. So it's about like 46 millimeters wide, 20 millimeters in depth, and the thickness is about 5 millimeters. Here's what it looks like when you want to apply it in the at the anatomy. So you can see the linear focus zone can actually embrace more anatomical areas at the same time, compared to the pinpoint focus therapy zone that the other devices produce. And what that means in practice is that you can treat a large area in a very short time, and not only treat the origin of the pathology, but also the changes that occur around an acute and a chronic condition that we see often in our practice. So, sorry, I'm just going to go back here. So, this technology was first used in the 1980s to actually disintegrate renal stones. And when they actually applied this high energy levels of focused shock waves up through the pelvis, they saw that the scatter or the deflected energy at a lower dose, which actually hit the pelvic brim, there they saw buildup of cortical bone. And then some German orthopedic doctors actually postulated that with lower doses you could treat bone lesions. And then they started applying focused shock waves to bone lesions, non-unions and stress fractures with great result. So here you see a radiograph of non-union gone wrong, where they tried to initially treat it with surgical implants, but after 2 treatments of Shockwave and after 14 months, we saw totally resolution of the fractures here. It was later confirmed several other studies, clinical studies, and also on stress fractures, where Tanki did a large study where we saw full resolution in about 85% of these chronic stress fractures, both at the pelvis, at the fibula and metatarsal heads, just after 1 to 2 treatments and immobilization for 4 to 6 weeks. So shockwaves can actually create a regenerative effect at lower doses on bony tissue. There's also been done a lot of studies on cartilage and collagen, fibers and hyaline cartilage and meniscus. And here's a study just to illustrate it, where they severed the avascular region of a rabbit's anterior meniscal horn. And they received 1 treatment, focused shock wave, in 1 control group, and the other one did not. And as you can see at the top pictures, that's where the lesion didn't heal up again, but just after 8 weeks, we saw totally healing of the meniscus tissue after 1 treatment of shockwave therapy. And that was just after 8 weeks. And similar studies have shown the same on human and animal tissue. So we know that it has a regenerative effect also on collagen. A lot of research and the clinical reviews have also been done on tendons, where it's, chronic tendinopathies have been studied, and we have quite a number of very good double-blinded RCTs, which shows that it has a very good effect on these conditions where they fail to respond to other conservative treatment and injectional therapy. And it's now been, has a high level of evidence in the literature to actually treat many of these tendinopathies that we see in the clinic, both with the elite sports people and also with the general population. Musculoskeletal pain and injuries are quite often hard to understand, and we don't know everything about the pathophysiology. But on the right side, you can see a normal Achilles tendon right here, attaching down here at the calcaneus. And here you see a thickened hypoechoic tendon with not clearly fibrillar structure. And you see thickening of the peritendon and structural changes down here in the Kager's fat pad. And what we see in many of these tendon and ligament injuries and also muscular injuries is that we see an ingrowth of neurovascular structures coming from the surrounding tissues. And in this place, it comes down here from Kager's fat pad. And we see an ingrowth of C nerve fibers and small capillaries. And they actually pertain the painful areas and the wrong supply of these tendons. So they create a wrong healing of the tissues. What focused shockwaves also have shown is that they can actually go in and when we target these neurovascular structures and C nerve fibers, which are producing the pain, they actually causes retraction and loss in number and ingrowth of these just by applying 1 to 2 treatments here. That's also why we often see a very fast response to pain levels when we treat with focused shockwaves, is that we actually work with the neurological systems to actually modulate pain. Here we see at histological level how it's actually applied, where they decrease in number and retract these C nerve fibers, which are causing the pain and dysfunction in tendons. Focus shockwaves are also shown to be superior to actually eliminate calcific deposits in tendons and muscles. And here you see a total resolution after 3 months, after I think it was 2 or 3 treatments this patient had. And we see the same thing in other anatomical structures, calcific deposits in tendons and muscles. And it doesn't seem to destroy the calcific deposits because they are of not the same hardness or density as other calcific deposits, but they seem to be replaced by healthy tendon tissue and musculoskeletal tissue when we apply focus shockwaves. So these parameters have been scientifically proven and investigated for focus shockwaves. It increases cell permeability by depolarization of the cell membranes. It stimulates microcirculation. It modulates a lot of pain substances and biological substances in the tissues, especially those who mediate pain and cell reproduction. It also modulates pain by reducing these non-myelinated nerve fibers which are producing the pain in the tissues. It also is a very, very strong angiogenetic factor causing vascular ingrowth in tissues or degenerative tissues which we don't have enough vascular ingrowth in. Has an antibacterial effect, and it stimulates growth factor in all kinds of different human tissues. Stimulates stem cells, and also has this modulating effect on pain modulation. So I don't want to dwell too much on all these small parameters, but what you have to take home here is that shockwaves or focus shockwaves can actually cause a rapid pain reduction or modulation. And it doesn't only happen at the periphery, but we also see changes at the spinal level and higher cortical levels. And we also see that it has a regenerative effect on both tendons, bone, ligament, muscle, and synovium. So for the elite athlete and for the general patient, it's a very good tool because it's non-invasive. It has virtually no side effects. It can speed up tissue recovery, both acute and chronic conditions. It can desensitize painful regions, and it can treat both superficial and deeper interarticular structures. We can actually focus ligaments, ACL structures which have been strained both before and after surgery, but also in the deeper lying structures like the hip, the labrum, ligaments around the hip and shoulder, and capsular damages. It can also actually help relieve. So due to that it's very specific in device technology, we can actually target these structures, and we can use it as a form of diagnostics where we can actually target these different structures and ask the patient if it reproduces the patient's pain. It will even increase the reliability and the effect of the treatment. It works very well on early bone and cartilage lesions, tendons and ligaments lesions. It has a very well-funded scientific effect on, but also degenerative changes in these structures, it can actually help. And even large partial ruptures you can treat that way. The more vascular the tissues are, like synovium and muscle, the faster the tissues respond, and you can actually speed up healing time by 50% in our experience. It also gives you the ability to treat lesions inside joints, which you weren't able to treat before, only by injectional therapy, which is not always indicated. So impingement lesions in especially the wrist and the ankle, sometimes the knee, it can be very effective on. And we also use it together with our sports medicine doctors, where we actually increase the effect of PRP injections, where you don't see very good results due to lack of activation of the stem cells that you inject. But science have shown that it has a very, very powerful effect on stimulating these PRP factors. So you actually activate it when you inject these substances and create a much better healing response. We also use them post-surgery after certain conditions, and I won't go into that in detail right now. So what you have to find out, what I found out is that after actually using and specializing this technology of focused shockwaves, we've been able to create a great growth and a new segment of our patients in the clinic. And we've also been able to actually develop as clinicians, because you get another dimension into your treatment. So with the focused shockwaves, you can actually cause regenerative changes to all musculoskeletal tissues. And you can also use a preventative overload. You can injuries and pre-competitive stages where you have soreness, you can actually treat. So you avoid injury. But most of all, we find it very exciting that you can use it as a diagnostic tool together with your physical examination. And we always use it in conjunction with an ultrasound examination to actually evaluate the anatomical structures of the tissues, and also to evaluate the progress, not only pain-wise and functional, but also to see how the tissues actually regenerate over months. So you'll be able to help a lot of patients who haven't responded to conservative treatment. That was a lot of talking for me in a very short time. I hope you could take some of these messages back home with you. And if you have any questions, I'll be glad to see if I can answer them.
So thanks very much, Anders. Appreciate that for the presentation. So now we're going to move into our Q&A session. So you find the chat box at the bottom of the Zoom. I've just posted a message in there, so it should pop up and tell you to submit your questions. Don't be afraid to submit your questions. Any question is a good question. We do have some pre-submitted ones, so just while people having a think and potentially typing. One of the questions that we had, Anna's, that was sent forward was, let's see if I can find it now. Yeah. Other than tendinopathy, what are the main things you would treat with focused shockwave in clinic?
Of course, tendinopathy is a thing that you see very, very often, both with athletes and with the normal population. But we see a lot of muscular strains and sprains and partial ruptures that we treat. We see a lot of ligament injuries, sprains and strains around the ankle and wrist that we can help, which we weren't able to actually address before then. We also see intra-articular lesions, early degenerative changes in cartilage and hyaline and fibrous cartilage, where we can help with the medial meniscus injuries. So all kinds of overload issues around the joints we can treat. We can also treat intra-articularly. As I told you, we treat sprains inside joints, like if you have a thrower's shoulder, where you have some spraining and straining of the coracohumeral ligaments and the glenohumeral ligaments. We can treat them instead of doing injectional therapy, which have not always shown a good sign of effect. So we actually have a lot of indications which we weren't able to get into before we actually had these devices to work with.
Cool. So, I mean, one of the questions that's coming from Angela. Hi, Angela. I hope you're well. How soon after surgery do you use the shockwave?
We work with several of our top orthopedic surgeons who treat soccer players, and if they have an ACL rupture, they refer to us just after surgery, or we come in and actually treat the patient after surgery straight away, just at the same time while they're under anesthesia. And what you often see is, like, if you have any metallic implants, like with an ACL replacement, you actually attach the graft at the tibial plateau. So you put the new ligament in there, and you screw in a screw to the tibial plateau. And in 5% of the post lesions, you actually see loosening of this screw by giving just one focused shockwave treatment around this screw where you inserted it, you create a very effective callus formation, and the screw actually sits firmly there and doesn't loosen. So all these kinds of niche conditions we use it for. We also use it for bone bruises where we combine it with the PRP injections. We actually, just after the injection, we go in there and give focus shockwave to activate the stem cells in the PRP injections. And it seems to have a much better response rate than with a passive PRP injection.
Brilliant. Angela, I hope that's answered your question. Next question is from Mandy. At the beginning, obviously, I said that we mentioned that using focus shockwave in conjunction with diagnostic ultrasound. Is this a requirement or a recommendation?
It's not a requirement, but it's very, very helpful if you wanna analyze the tissues that you want to treat. With the new high resolution ultrasound scanners, we can actually see quite deeply into the tissues, and sometimes it is helpful to verify the anatomical structures to see if it's a partial rupture of a ligament or tendon or it's a full rupture. It just helps you guide your treatment. And if you don't master it yourself, I would also always actually recommend that if you are in doubt about the lesion site and what's going on in there, refer for a scan or an MRI scan so you actually know what's going on. But the good thing about the focus shockwaves is, as you can, just by knowing your anatomy and you have some palpatory skills, you can actually go into the different joints and target different tissues. And you can ask the question by biofeedback, if this treatment reproduces their known pain, then you know you're on the right way.
Brilliant. So I hope that's answered your question on that, Mandy. There's quite a few questions coming in. So John has asked a question. I'm just going to unmute John. It's quite a long one, so I just want to make sure we get the question right. So John, you are unmuted if you want to ask your question to Anas.
Yeah, about 3 months ago, prior to lockdown, I was treating a fell runner, a cross-country runner, and he had a chronic, very thickened Baker's cyst. And on compression on sonography, one could see that there wasn't much movement in fluid, and the cyst was definitely communicating with the medial meniscus, but no meniscal pathology could be seen in the posterior medial corner. I treated one time prior to lockdown, and I reviewed the patient actually today, about 2 hours ago, and the patient had a remarkable response. On sonography again, there was no change whatsoever in the size of the Baker's cyst, and it was very, it was immobile, but there was phenomenal improvement in function on one treatment, and the patient came back because he felt he should, but it didn't need to. So one treatment seemed to resolve this problem. So my question is, can you discuss the possible mechanism? Like, one cannot use sonography to assess meniscal tears adequately, but what are the possible mechanisms for this great success with one focus shockwave? I use an EMS piezoclast.
Yeah. Interesting question. It's been mind-boggling us clinicians for many years, especially me. A Baker's cyst is, in my opinion, just a sign of some form of intra-articular damage. So it's just increased production of the fluid within the joint. And then you have to, as a clinician, work around and to see what's going on here. And as you say adequately, we cannot evaluate the whole part of the meniscus probably by using diagnostic ultrasound. I always require an MRI to see what's going on there. But your examination will often show you if this person is a candidate for surgery, because they have to have blockage of the knee and they're not able to load it. If you just have increased production of joint fluid going into the Baker's cyst, I would look at the sites which can actually produce pain in the knee. And where we can actually elicit pain is where we have some nerve innervation. And when we look at the different structures, it's only about the outer 4th, 5th of the meniscus, which is actually innervated by nerves. So the joint cartilage, as long as it's hasn't gone through to the underlying bone, we most often we see the pain production from the outsides of the meniscus. And often you see the pain at the medial meniscus where you see most of the injuries. And if you have a very high resolution ultrasound scan, you can often see that you see some effusion underneath the medial meniscus at just between the top of the tibia. And there you see small changes to the deep coronary ligaments, which are actually part of the medial collateral ligament. And if you twist and examine the knee properly, you will often find that's what's causing the pain. And you create a very good pain reduction by actually targeting these areas. So you don't affect the fluid levels in the Baker's cyst, but you actually pain modulate by modulating the pain in these receptors at these sites at the medial knee joint. That's what I think.
No, that's a great answer. It's I suppose it's correlates in parallel with maybe my thoughts, but it's great to have the opportunity to pose this as it's a fresh hot off the treatment couch from this afternoon. Thank you.
Thank you.
Perfect. Thanks, John. So, Anders, we have another question from Mark Barton. Could you give any guidance on a dose for lateral epicondylitis?
Yes, I can. Primarily used with moderate to low, like doses. You still have to adjust it to within the system that you use, because as I told you, the pressure values of each system is different, and the density of the focal zone is also different. But between 0.1 to 0.3 millijoules per square millimeters is enough for the working dose, and I give about 2,000 to 3,000 impulses. The detail with... Sorry, Siri is talking to me. What we see in the literature is that by medial epicondylitis and lateral epicondylitis, we see not that good results. And in my opinion, it's because to poor treatment protocol and precision. You're actually treating an area with a diameter of about 2 or 3 millimeters. And if you just slide off slowly from these structures and don't give them the right amount of dose, you have to really skin mark the site, and you have to sit and look at it while you give the dose. If you slide off and actually activate other areas, you won't get sufficient dose to create the regeneration and pain modulation.
Perfect, thanks for that. Next question we've got is from Angela. I'm just going to unmute Angela so she can ask her question. Angela, are you there?
Yeah, I can hear you.
Lovely. Go on, go ahead.
Hi, Anders. Just wanted to know, you talked about hip label tears. How do you position the probe and things to treat the hip label tear?
Yeah, we see nearly 90–95% of all labral injuries at the anterior part of the labrum here. So they're quite easily to actually visualize and also to go in to treat again. So I put the patient in a frog leg position, and I go in and actually treat straight down into the capsule and try to elicit the known pain from the acetabulum or from the femur or from the labrum by itself. And it's quite easy to find if you actually position the patient like that. Palpatory is very easy. You take the inguinal ligament, you palpate for the femoral vascular neurovascular bundle, go just a little bit lateral and about an inch down, and you'll be right on top of the, in front of the front part of the hip joint. And you should not go further than 3 to 5 centimeters down before you can actually target the tissues.
Okay, that's great. And the same with post-surgery, I suppose. We see both acute injuries and then post-arthroscopies. Is that the same if there's a lot of scar tissue and then on the psoas? Is that the sort of same position you would target?
Exactly. We see a lot of post-surgical scar tissue formation, which causes persistent pain, and they respond excellent to a few treatments of focused shock waves.
Okay, thank you.
Welcome.
Thanks, Angela. So next question is from Abid. What is the most common pathology focused shockwave is used for?
I think it's probably chronic tendinopathies. That's where we've done most of the clinical research and seen the best results. If you apply that together with a comprehensive exercise regime, it has the best evidence right now for treating those conditions.
Brilliant. So one of the questions I've actually got is, you mentioned obviously that focused shockwave can help generate bone, but it can also disintegrate calcification in tendon, which seems a bit counterintuitive. Can you kind of explain how that might be the case?
Yeah, I think with those doses that we use within our practice here, we cannot really cause disintegration of these calcific deposits in the tissues. We can also only cause replacement of healthy tissue. We can actually measure these calcifications in the tissues, both with high definition ultrasound. We can see if they have acoustic shadowing or not. Some of them are just very like gelatinous calcifications, which are not real calcifications like an osteophyte. And if we are in doubt, we actually refer for a CT scan, which can actually measure the density of these calcifications. So most calcifications in the soft tissue are not of the same density as we see with bony lesions and osteophyte formation, which cannot be affected by focused shockwaves. So I think that we're not actually destroying the calcification, we're just replacing it with healthy tissue. So it disperses that way.
Perfect, answered my question anyway, thank you. One of the pre-submitted questions that we had is around business. So obviously you touched on before, there's radial and focused shockwave. So for you as a focused shockwave user with piezo wave, how does having focused shockwave differentiate yourself from other clinics, and how do you market that and get that message out there?
I think we market that because we actually treat, it markets itself because you treat all these conditions which haven't responded to conservative treatment, radial pressure waves, exercise therapy, injectional therapy. So if you actually help one of these triathletes, marathon runners, or football players with ligamentous injuries, they refer a lot of patients their way. And that's also what we actually see, that when you start using focused shockwaves, you expand your cooperation with other colleagues, physiotherapists and specialized doctors. So you work together and form another network in how you actually manage and treat your patients, because we always think here in Denmark especially that you should use the least invasive measurement to get these patients better, and if it has no side effects, you should choose that first. So we only refer our candidates for surgery if they're needed, or if any other treatment fails. And with focused shockwaves, you get an extra dimension to actually your treatment. You get a diagnostic dimension, and the patient is actually able to feel the first time that you're targeting their known pain. And that creates a great response, both psychologically, but also how they actually adhere to your management and how they refer patients for it.
Brilliant. I think, and following on from that, from the same clinic who just recently invested in focused shockwave, is that they're obviously trying to figure out the return on investment. So do you charge an additional fee for shockwave, or do you incorporate it into a standard treatment?
We here, most countries, you actually charge an additional fee because it's an additional technology that you use and more time consuming. And often it's just a part of the treatment. Sometimes you have to do some manual treatment, or some you have to advise the patient, or you have to give them some exercise advice or some other therapy. So we charge an extra fee for it. And we figured out with those devices that we have now, if we have 2 treatments a week, then it pays our equipment in our leasing efforts. So everything excess of 2 treatments actually goes into your own pocket.
Perfect. So I think if anybody's got any more questions, clinical, business-wise, please put them forward. I've got a couple more pre-submitted questions that were sent in before the webinar, which I'll just go through now. But please, if you've got any more questions, then just send them in on the chat again. One of the questions is, what would you advise clinicians whether they need to buy a more expensive, quite frankly, you know, focus shockwave we know is a little bit more expensive than a radial, which they can buy for less. What would you say to those clinicians if they're looking at the types of devices?
Well, radial pressure waves share many of the same indications, and they can also work very well in supplement the focus shock waves too in many conditions. But the focus shock waves has, as I told you earlier, it has a much wider application sphere. You can actually treat all human tissues, not only superficial ones. And on top of that, you can actually target tissues which are very painful to palpation and manual therapy and radial pressure waves, because it's not creating any mechanical tension and provocation of even acute sprains and strains and lesions in other areas can. So you can treat both acute conditions and chronic condition with less patient discomfort, and you can treat a lot wider area of injuries because you have the penetration depth to take into consideration too. So even though it costs 2 to 3 times as much, it's only been an economical advantage for us to actually invest in the systems.
Perfect. And I mean, can you tell us why, obviously you were one of the key influences to one of the reasons why we got involved with piezo wave focus shockwave. I mean, can you tell us why you've let you sort of use that system more?
I think just like with any other technology, it develops and evolves, and the piezoelectric system is just very, very easy to operate. It's very reliable. There's no maintenance on it, so we don't have any maintenance costs. And the systems that we've had now, the piezo wave 2, we had for 3, 4, 5 years, and we haven't had any problems with it, and they still work perfect. You turn them on and turn them off, and they're very easy to operate. And because they are so concentrated in a focal zone, and you have the possibility of the linear and the focal device, it makes it very versatile to treat any anatomical structure in the body, and very quickly too. So it's just a very easy product to use, and it's the most powerful one. So I can treat less times with a better effect than by using the other systems. We have 2 other systems at the clinic, 2 electromagnetical systems, but none of us are using them anymore because the piezoelectric devices are much easier and faster to use, and they're more cost effective. It's just like switching from manual gear to automatic gear. You never go back.
I haven't gone to the automatic yet, so I'm still yet to make that move. Chris, you have a question.
Hello.
Oh, he's unmuted himself. Go ahead.
Sorry, I missed the middle part of the webinar because I had to quickly scan a patient. And interestingly, the patient was an Achilles tendinopathy. So my question, I've been teaching diagnostic ultrasound for years, been using it for years, and I always tell people that we shouldn't use diagnostic ultrasound to monitor injuries, particularly tendinopathy like Achilles patella tendon. We know the correlation is poor between imaging and pain. So I use Radial. I know that's a swear word, but I'm looking to get one of these systems. Is this going to change the game for me? So am I going to see an Achilles tendinopathy, do however many sessions, which is my first question, how many sessions generally do you do? And am I going to see a difference in the quality and the structure of the tendon? If I am, when is that going to be? There you go. Let's start with those questions.
Okay, thanks, Chris. It's very true. Like any other radiological evaluation, you have to take into account that it's not always the truth what you see. So you can evaluate just like progress and severity of the injuries. And when we talk about tendinopathy, it's many things. We can have an acute or chronic inflammatory tendon, ingrowth of these neurovascular structures. We can have involvement of the peritendon and surrounding structures, like we see in the shoulder. And also when you see, look at the Achilles tendon, we have to focus on the fat pad. What we see is that I like to use the diagnostic ultrasound to actually target which tissues that I treat. After treatment, I can actually see the reaction in the tissues. I can see the neovascularization after focus shockwave treatment.
So can I ask you that? So immediately after, you will see an increase in your hyperemia?
Immediately after, yes. Just after the treatment.
Yeah. Okay.
And that's just a sign of you stimulate that. And you stimulate also the C nerve fibers and alpha nerve fibers which lie down there. And that's just an indication that you stimulate the whole bundle. And that's what causes the immediate loss of pain for 24 hours afterwards as focus shockwave therapy session. And what I also do is that normally I can see tissue changes in the tendon, but you don't see them before 3 to 6 months afterwards, depending on the general change or if you have an acute change in it. If you have an acute overload, you will see a change in the tendon tissues within 3 to 4 weeks. But with chronic tendinopathies, it lasts at least 3 to 6 months.
Okay, cool. Yeah, I was expecting you to say that. And I think you mentioned, what's your average number of treatment sessions? Sorry if I missed that, and sorry if I'm repeating it for other people.
Well, no, you're just actually helping me because I haven't said anything about that. For the Achilles tendon, I treat 6 times. 6 treatments.
And where does that number come from? Because we all treat radial 3 times, but it's just that we don't, is there a dose-dependent response? Is there a ceiling effect, do you think?
If you've been working with it for as long time as I have, and I travel all around the world and talk to all different colleagues and researchers, is that one thing that the research shows that all the studies with increased energy level, increased number of treatments, you get better results with the focus shockwaves.
Right. But do you think there's a ceiling effect? Do you think like no more than 10 or?
No, I don't think there's a limit. I have some pictures.
And how often would you do it? What's the closest you would do it? And do you ever do it further apart than, like a week or?
Yeah, I do it twice a week to start with, and then I go down to once a week until there's a pain relief. It doesn't seem to have a big effect if you prolong the treatments for 2 weeks or 3 weeks. That doesn't seem to have any effect when you look at the literature. And many of the things that I'm telling now is also clinical experience from my side.
Of course, yeah.
So that's what I feel works the best, and that's the protocol we tried out and we evaluated many times, but that seems to work the best for us for chronic tendinopathies.
Yeah. One more question. Stop me, Mark, if I'm going on. So I've just seen this lady. She's got a retrocalcaneal bursitis. She's got calcification, enthesophyte, and a thick tendon. She's also got a small ventral surface tear. Are we saying that Shockwave, you just do it? It will help all of those structures. Doesn't matter what specifically is driving it necessarily. Yeah.
We don't really know what it's, how it's working 100%, but that will definitely help these kind of indications that you just mentioned here.
Okay, but it's quite non-specific then in its effect.
It's specific in it, like pain modulation wise, it's not specific. But depending on what stage and what tendon you're talking about, we see different changes.
And would you treat it for a paratenon as well as a partial tear, as well as like a chronic partial tear?
Yeah.
Yeah. Would you treat it for an acute tear?
Yes, definitely.
Would you, and bone stress you would? I think I heard that.
Yeah. We treat a lot of stress fractures with.
Does it not feel sometimes that you're just treating every condition the same?
Yeah, but nearly. But there's a difference still. With bone lesions and with the calcifications, we treat with a higher energy level and less treatments. You only need 2 treatments for actually getting a full response in these tissues.
And last question, I promise. If I've got a bit of supraspinatus in my tendon and there's an acoustic shadow, I think you said it at the end, am I going to get rid of that?
It depends on how big it is and how dense it is. And you cannot...
1 centimeter with acoustic shadow. Another patient I saw earlier.
Everything more than 3 millimeters, I would not treat.
You wouldn't treat it, or you wouldn't expect it to change?
No, but I would... you have to evaluate when you do dynamic ultrasound if there's impingement or if it's just pain being produced by it. So I cannot just evaluate it by looking at it. I'd also have to see which clinical indications it's actually creating for the patient.
But I assume you've had calcification in the cuff that you've done focus like 6 to 8 times and you've seen it go on ultrasound?
Yeah.
And how long do you think that process takes if it happens?
It takes up to 6 months before it disappears totally. But
Cool.
we see about nearly 90% success rate in total reabsorption of these injuries.
90%
90%.
on focused after 6 months?
Unfocused.
With acoustic shadow or without, or it doesn't matter?
Doesn't matter.
Brilliant. Thank you very much. Sorry for all the questions. It's a lot of money to spend. So
You're welcome, Chris.
Really helpful. Thanks, Chris.
Exactly.
Right, so I think if nobody has any more questions, we will wrap it up there. So I'd like to say thank you very much, Anders, for your time and your expertise, and thank you everybody for joining us and participating with your questions. We hope you enjoyed the session. Following this webinar, you will receive a survey with a link also to the webinar recording. We'd really appreciate any feedback that you do have and any suggestions for any future webinars as well. So if there's any particular topics that you'd like us to cover with Anna's, or if there's any other speakers that you might want to hear from as well, then let us know. We welcome any suggestions. The other thing we'd like to ask as well is we are running a clinical ambassador project where we want to work with people who are really forward thinking and can see how this technology will enhance your clinical practice. So if you're interested in this or have any further questions about Focus Shockwave, Piezo Wave, or like any more information, then please get in touch with us. Our email is info@physiquip.com. Otherwise, thank you very much and have a lovely evening. Thanks, Anders.
Thank you.
Bye now. Bye-bye.
Bye.